I want to introduce Karen Little, although I'm saying it wrong. It's Karen. And we like to start these policy forums by asking someone who's been through it, who's had some lived experience, who can share what their experience has been to kind of keep us all grounded. So, Karen, I'm going to invite you up.
Good afternoon. Welcome. It's an honor for me to be here. And now at least there's not two headlights. Now I'm the deer in the one headlight. So I am the client expert from the Client Stakeholder Project of the California Association of Mental Health Peer-Run Organizations. I know that's a mouthful. Here today. I have lived experience of having gone through a lot of trauma, having multiple diagnoses, mental health diagnoses, of having substance use challenges. Last Tuesday, I celebrated 23 years clean and sober. And in addition to other medical issues. So I come to you with that perspective. I've also worked at the state level. I worked under Working Well Together in the southern region. And my trade is really vocational psychiatric rehab counselor, so helping people with psychiatric challenges back to work. And I got to, work with that with the state for a while and loved it. And so I just want to briefly say that, first of all, the people that you serve, those are the folks who pass through all those silos, or at least they attempt to. Sometimes they don't make it. That's the whole point, right? So the integrated approach where we consider the mind, body, and the spirit, that is the peer support approach. And I worked long and hard on peer specialist certification, and there that I'm talking about consumer youth, family member of adults, and parents of children as peer specialists. And now we have the privilege that the Planning Council, we've all been partnering, and the Planning Council, the Advocacy Committee, is now ready to push that to the legislature for statute, for peer certification, so that then we can actually have funding to move it forward. But I do want to just mention that there are at least 5 different whole health peer specialist models out there. And I know one of them that's already evidence-based practice, and that's the WHAM, the Whole Health Action Management. And even in Georgia, their peer specialists there are able to bill Medicaid for up to, I think, $25 per 15 minutes. So I would like to see how we all can partner to ensure that our needs are being met all around. I'm lucky. I have a psychiatrist who takes my blood pressure every now and then. She recently wrote me a prescription on a prescription pad, and I'm like, oh no, okay, well, we always discuss all the meds. And she handed it to me, and it was a prescription for meditation. Now that's what I'm talking about, okay? But wouldn't it be great if we had peers as a very cost-effective workforce able to provide some of these services as wellness coaches and peer navigators? And that's what's going on all over. And I hope that we can work together to make that happen more effectively here in this state. Thank you.
Okay, I'm going to ask our state representatives to come on up. And while they do, I'm going to give you a few housekeeping issues that I always get to do. The first one is that if you are parking for the day, it's $10. If you're going to be here overnight, it's $20. Continuing education credits are available, so if you go out to the front desk, you can get your CEUs. We want you to fill out the evaluation forms, of course. And last, please visit the exhibitor booths. Thank you. Come on up. So as they get settled here, I'm going to introduce Karen Baylor, who will introduce her colleagues as well. I have to tell you, after working with DHCS for quite a while, and we have, it was very frustrating for a long time to talk to folks there who knew absolutely nothing about what we were talking about. So it was a real thrill, and I tell you, I've been really pleased to have Dr. Karen Baylor at DHCS, because she's got a long history of working in mental health and substance use disorders in the private section and in the public sector, both. So when I talk to her, I don't have to explain every word that I'm using. So it's been wonderful to have you there, Karen. Thank you so much.
Thank you so much for inviting us. We're thrilled to be here. I have to start with, just let me vent for just a minute. I thought this was going to be a living room presentation, and so we had planned, we had this whole thing planned regarding this living room thing. We were going to do like DHCS, unfiltered, unplugged, and just have a conversation, and we all went out this week and bought slippers because we were going to make ourselves comfortable. So we had this whole thing planned for you all, and here we are back at the table.
Did you wear the slippers?
No, but we have slippers for sale. If anybody has forgotten a pair, come see us. So thank you again. I do want to once again introduce, and I'm sure you all know the folks with me, and we have a number of topics we do want to touch base with you on and give you some updates. But first of all is Marlies Perez, who is the division chief for SUD Compliance Division, Brenda Graylish, who's the division chief for Mental Health Services, and Don Braeger, who's the newbie on the block, the division chief for Prevention, Treatment, and Recovery Services. So it's hard for me to believe it's been a year. I can no longer say I'm new. Darn. But Don can. So whenever there's a difficult question from you all, we're all going to look to Don, and Don's going to say, I'm new. So that will work. And then I don't know what we're going to do in a year from now. So let me start with, I think you've probably all heard about a certain person who's leaving a certain large state organization. And for those of you who don't know, Toby Douglas has decided to call it quits. These are really, really hard jobs. And he did it for 4 years. The national average for any state Medicaid director is 2 to 3 years. So he did it an extra year. He does have small kids. This is at minimum 60, 70 hour a week job. I just think he just can't do it, physically just can't do it anymore. And we're very sad about it. And whatever you think about Toby, let me just tell you from our perspective, he is a very unique individual, and we're all, I mean, the sadness in the building last week was just unbelievable because he's such a dynamic leader. Not only is he incredibly smart, but he has social skills, he has integrity, and he really cares about the people that we serve. And I think there's tremendous shoes to fill, and I feel badly for the next person coming in because we're all going to be saying, well, Toby wanted it this way. And I've worked in a lot of organizations over my tenure here in behavioral health, but I have never worked in an organization where you never, ever heard any negative talk about the boss. It was all positive. It was always what can we do to help? It was always very positive, and so we're all very sad about him leaving, but we stay on path. We embrace change, and we stay on path. And so after he announced to all the managers and supervisors, I pulled my team together and said, we stay on path. We have come so far with behavioral health being integrated in the Department of Healthcare Services. We cannot go back at this point. It's worked out really well, and we're a team, and I don't want to do my job without this team, because these folks here are incredible and have integrity and passion for the work that we do. And so we all did a pinky swear that we weren't leaving. Don was a little, but
I'm new.
So, I really just publicly want to thank the team, because these are really hard jobs, and I don't want to discount the fact that you all have hard jobs too. It's just the amount of stuff that flies at you every day. Just to give you a flavor, we all get about 300 emails a day. Half of them are, I need this by close of business. And, where is this document? Where is that? It has to go through all this review process. And these folks are what make us be able to push our policies forward. They have great staff who are thoughtful and care about the people that we serve. And so I'm very, very grateful to have the team that I have to make this all work. And so as we move forward, I had an interesting conversation about a month ago about someone who asked me, since I've worked in the nonprofit sector, I've worked in the county environment, and now at the state, can you compare and contrast the different things and how you move things through each system? And so on the plane down this morning, I spent some time, and you're not going to be able to read this by any means, but I just want the visual. I spent some time going through, crap.
What do you want me to pull it out?
Pull the pen out.
Pull the pen.
Sorry.
Other duties as assigned. She never lets us touch your pen.
Thank you.
It's a special Braeger.
We do have fun together. So I spent some time on the plane thinking about, if I had an idea and I wanted to hire a new staff, what are the steps that I would need to take when I was in the private nonprofit sector? I came up with five steps to hire a new staff. If I had a great idea and I was in the county system, how many steps? I came up with 20 steps to hire a new staff. In the state system, 35. So because I've sat where you've sat, when you get impatient with us and think, why can't the state just make a decision? Think about this. This is why. There are so many steps that you have to go through that I'm thrilled to be able to give you the information that we have today and to keep the conversation going. And I often go in and talk to Toby about issues, and his common response is, Karen, state bureaucracy. So we try to figure our ways around it and to get through it so that we can get you the answers that you need. And so with that, I'm going to, we've got some issues we thought it might be interesting for you all to talk about. And so I think probably the number one question and the number one topic we get asked about and the number one priority for us is the SUD waiver. And so the way we have this established is Marlies is the person in charge of doing the standard terms and conditions. She's done the narrative piece. Don, bless his heart, has taken on the financial piece. I'm telling you, I had a meeting once where we did budget neutrality, in the morning. I then had a realignment meeting in the afternoon. I was in bed by 8:30 that night. I was exhausted. I was like, can I diagnose somebody? Give me somebody to diagnose. Because the financial pieces are just, they're complicated, and I'll let Don talk about that. But I'm going to turn it over and let Marlies give you an update on where we are with the waiver, and then Don can do a little bit on the financial. Not much, but a little.
Great, thank you, Karen. And thank you for starting the session by depressing me about Toby. Yeah, thanks. At least I have someone that can diagnose me and take care of me. We have weekly, she calls them one-on-ones, I call them therapy sessions. So, but yeah, we have received a lot of questions about the waiver, and I think most folks in the room know about the waiver that we're pursuing. For the 3 people that don't, basically the department is pursuing an amendment to our Bridge to Reform waiver. And I do really want to just quickly highlight, because what this conference is about is partnerships. And while we are doing the terms and conditions at the state level, because that's what's required to submit to CMS, this has just been another great example of partnerships. And so when the state put together the meetings in April, I mean, we just like threw them together. It was just, we're on a roll, we want to do this. And what I really want to thank all of you for is you all showed up. You gave up 2.5 days of your very busy schedules. There's been countless emails and comments. And one of my staff that's relatively new to this field, they said, wow, the stakeholders are so interested and willing to help. And I just really sat and thought about that. And it's not like that in all fields. Sometimes you really have to pull teeth to get people to the table. This group's like, okay, the table's only so big, we can't, ooh, the room's full now, and oh my gosh, now they're outside. But what I love about that is it shows the passion and commitment that folks have for the behavioral health field. So I really want to thank you, as we are the ones kind of carrying the torch right now over to CMS. It's only because of all the work that you folks have done and helped us with. I've reached out to a lot of you in the room, what about this, that, and as we continue to craft and get down to the details, because we're not the experts, we're coordinators, and while we have a lot of the subject area materials, you guys are the ones on the street level, at the county level, or at the provider level, doing this every single day. And so our ultimate goal is we want this to work. And you can't have a system like this work without the partnerships. So, and CMS has really recognized that. And what we want to bring to you today is, because we have been getting a lot of questions about what CMS is feeling about the waiver, and they have read our draft terms and conditions. And I'm very excited to say that they have given us the green light to submit the waiver with the residential piece, because I know there's been, yep. Thank you, yeah. So for those of you that are like, what is she talking about? Basically, part of our waiver in order to lift up the system and have the organized delivery system is we need that continuum of care. And we need to be able to provide services in our residential facilities larger than 16 beds. And we've been meeting with the OMB, the federal level, and so we've got the green light. So we are just like, we've been battling this for years and years and years, and here we are, we're going to be able to show the nation that this works. And what also really excites us is CMS has been so appreciative of us teaching them about substance use disorder services, and that California is in the lead, is just leading out on this once again. And so we're just so excited about this opportunity. They're pushing us forward like, okay, how fast can you do this? Come on, speed it up. And we're just like, okay, come on. Toby, he's like, woo, way out front, like, come on, team, we want to get this submitted. So we're working fast and furiously. We have completed the terms and conditions. We've been working on the budget neutrality piece, like Karen mentioned. Don and his staff have been, night and day getting that worked out. We've been working on the fiscal piece. So our real timeline now is we're kind of getting the budget neutrality wrapped up, working on the fiscal. Once we get that fiscal done, we're going to be submitting to CMS. So we're really, really hoping, our timeline right now is October publicly stating this, to submit this to CMS. Once again, we have been working with them along the way, so it's not like this is brand new to them. They've seen what we're doing. We've been working with our federal partners at SAMHSA. They want to be involved in this as well. So we're just getting green lights everywhere. And so we're just thrilled. We're thrilled about this opportunity. We, like Karen said, it's really all about the waiver, even though it's not. Everything else is still continuing. But we really have moved a few mountains to make this happen, and I know you folks have as well. So that's our timeline, and then I know the next question, so when would it start? When would it start? That's really going to be up to CMS. They know that we want to get this going right away. So that's, but as that continues on, we'll provide you with more information. So Dawn, is there anything you want to say about the fiscal?
The two big pieces of the waiver, coming into this job 3 months ago and then jumping on board to, wow, you're going to work on a waiver. And that was, what's a waiver? Great. And then working with Marlies on the terms and conditions, which was the narrative piece, that was a lot of fun. And then I got the fiscal piece. And then I had to work with things called PMPMs and now PUPMs and working with all these things I've never heard of. And frankly, thank goodness we have rocket scientists on my staff that understand these things, and they do great work. They've really helped to push it along. So two main components are budget neutrality. You have to show that, that the waiver will be budget neutral. And so there's some components of that. We're looking at historical costs over the last 5 years, really looking at the IoT versus residential benefit. We have to map all of that out. And then really the last component is how we want to propose to repurpose or use some of our SAPD funding, substance abuse prevention treatment funding, for some of the continuum services that we're proposing in the waiver, for recovery services or the residence component. So a lot of work has gone on in a very short amount of time, and like these guys have talked about, it's a fast-moving train. There is no time to stop and get educated. It's just really you grab people from everywhere, and it's stressful, but at the same time, it's really exciting where we're going. So I'm excited that we're wrapping things up, and I think we should have the fiscal pieces done in the next, hopefully, 2 to 3 weeks, which should then combine those with the terms and conditions. So that's the work we've been doing on the fiscal component.
So, as you know, we do have a current 1115 Bridge to Reform waiver that will expire next October. Work has already begun on renewing that waiver. The pieces that we're doing for DMC and SUD will fold into this new waiver, so that it'll be ongoing. And so we don't want people to be nervous about jumping into the waiver thinking it's going to end in a short amount of time, because it won't. We'll just continue on. The other thing we have promised the waiver advisory group was that we would come back to them and walk through the fiscal pieces. Obviously, that won't be me doing that. But once we get everything really nailed down and worked out, we'll be able to get that scheduled and have some people who can walk that through so that you understand the fiscal components of the waiver. Couple other things, just quick to announce. Our SPA for the expanded benefits for SUD finally got approved by CMS. Woo-hoo! That only took 10, 11 months. So that's now posted on our website if you haven't seen it. 13308 is, but we just keep in mind we had to pull out the residential piece. So the expanded benefits are all laid out there in that SPA. Let's see. I'm going to have Brenda talk a little bit about the behavioral health forum and kind of where we are in working with the managed care plans.
Okay. Thanks, Karen. Thank you so much for having us here again. I think it was a year ago was my first policy forum as well, so it's really awesome to come back here after a year and a lot of experience. It's amazing how much experience one can accumulate over a year's period of time. But as my colleagues here have said and mentioned, things move very quickly at the Department of Healthcare Services, and that's an exciting thing. And coming into this job a year ago, we were preparing for the rollout of the ACA, and coming from corrections, the California Department of Corrections, it was a totally different world for me coming, back to mental health, because I'd spent the first 10 years of my career in mental health, but really coming back to the field of public mental health and kind of seeing how our world had expanded and how we were starting to collaborate or begin our collaboration or even closer collaboration with the managed care side of the house, and then also with substance use disorders, former ADP. So we've got so many efforts underway, and I'll just give you an update on a few key efforts that we've been involved in that involves the integration of these services. So one of them being through the ACA, the requirement for the managed care plans and mental health plans to revisit their MOUs. It was due on, or the MOUs for each of the plans in the counties were due on June 30th. We issued some all-plan letters to give some guidance on the managed care side of the house. We did information notices, so our new MHSUD, so we are not just mental health or substance use disorders, we do MHSUD info notices or information notices, just to provide guidance with the rollout of the ACA. We worked very closely with our managed care partners and our substance use disorder partners. From my perspective as being the mental health services division chief, we worked really closely and collaborated within our department and with our stakeholders to put this guidance together. Got that out, and really working to build effective working relationships between the two plans, the managed care plans and the mental health plans. And so with the MOUs, the requirement is to cover key areas such as screening and assessments, appropriate level of care, coordination, timely information exchange. We call them the warm handoffs and the hug back between the systems as people move through based on their needs at the time for services, recognizing that people are not static in their conditions. And then, we think it's been going very well. We haven't heard, there was maybe a couple little hiccups in the beginning that were kind of rising up to our department, but really it necessitated a conversation and just providing clarification. We haven't heard, I don't think, anything about people, not getting the services that they need, which has been great, but we're continuing to monitor the situation, and we're always here. So if folks have questions, please contact us. So we're looking to convene some regional calls. So the Department of Healthcare Services is looking to convene some regional calls in 2015. Will be hosted by Managed Care and Mental Health. And I assume SUD would be involved because we're all trying to keep a finger on the pulse of each other's areas, just to see how things are going in the field, and if there's any issues that we need to focus on. We've noticed that those who were the managed care plans and the mental health plans who were involved in the CalMedi Connect had some, experience already in coordinating the care for behavioral health services, so they were a little bit easier to continue on, and we're looking for them to share some best practices. So to date, we've got 27 executed MOUs, 4 unexecuted MOUs that are being processed, and 35 extensions that have been requested. I think the last time I heard we weren't going too much farther than September, October, really pushing to try to finish those MOUs. So we're following up with managed care plans and mental health plans. I think there was an email that had gone out for the managed care plans, and then I had sought out assistance from CBHDA to get an email out. So many of you guys have been sending your MOUs to me, which thank you very much, and I've just been forwarding them on to our managed care plans. Those folks, managed care's got the lead on it. They're reviewing the MOUs. I have staff on my team who are participating in those reviews, so we're continuing to work closely together. Which brings me to another effort that we've had underway for the past year, and that's the dispute resolution. So we convened a work group to seek stakeholder input regarding what would happen if disputes arise between the managed care plans and the mental health plans. And the idea, or at least kind of where we landed, is to have disputes resolved at the local level as much as possible. If there's situations where it can't be resolved, then it would come up to the state level. But so far, counties and mental health plans have been doing an amazing job at kind of figuring it out and kind of working through those issues. We had been asked to define moderate, or do we need to define moderate? And again, at this point in time, the work group decided to maintain the status quo on the MOUs. We're going to continue to monitor that and make sure that it's working. There was a work group on data sharing. So the local plans are working on getting data sharing agreements together so that they can track folks that move between the systems. And then we'll be convening, I think within the next 2 to 4 weeks, another work group on difficult diagnoses, so diagnoses that hit both systems, such as eating disorders, so to kind of think that through. So that's pretty much where we're at with our memorandums of understanding. And then another update that I wanted to give was on the performance outcomes system. So this, for you guys that know me, this is one of my pet projects. So it's a little near and dear to my heart, but I'm really excited. We got both of our legislative reports. So since I last updated at the policy forum last year, we got our system plan and our system implementation plans submitted to the legislature. Our team has been working really hard on reviewing the data in the CSI system. As of May 31st, 81% of the counties had submitted CSI data within that 60-day period of time, which is awesome. So great job, you guys, getting that data into us. It's really critical for our launch of this performance outcome system. So our team has been working on data quality reports. There's a subject matter expert performance outcome system work group that's been working to identify primary or key data elements for reporting, and we're looking to come out of the gate with our first initial reports in December. So we're still on track for that, pushing really hard to keep that deadline in place. And then we're also embarking on a study of performance outcome system or functional assessment tools. I think I mentioned a little bit about that, and I've kind of given some updates throughout the past year that we are going to contract with the university to kind of find out the state of the nation, state of the state, what counties are doing, what's working, to seek a recommendation on where should we be headed as a state in terms of determining whether or not the people we serve are getting better over time, or what does the picture look like. So we're really excited about that. And then we've been working with the KDA implementation, working with social services to get a memorandum of understanding in place to share data, and then working with our managed care plans, again, continuing that integration, not just with the services, but also with the data, to be able to track people as they move between the two systems. And then now we are required to do 2 more reports on a system plan and a system implementation plan to talk or add in what we're doing to measure or to monitor the people as they move through the systems. We're also embarking on a data modernization project. So we're working with the Oversight and Accountability Commission, the Planning Council, and then with our internal IT, we have some very antiquated data systems. So we're looking to bring those up to up to speed with the latest requirements. And then the really exciting piece of our performance outcome system is implementing that quality improvement piece. So not only just collecting the data, producing reports, but then now using that data to make improvements. So we had a BCP that came through. We got 4 new positions, 2 for the performance outcomes for the data collection, 2 for quality improvement. So we've got half of those staff hired, and we're just really excited about that. And then I think my last one. I know, sorry. We're busy. We have a lot going on. The Behavioral Health Forum. So just we had the launch of our Behavioral Health Forum. We had 2 kickoff meetings earlier this year. We had our first initial meeting in July. We've got another one coming up in October 2nd. We've got now 4 forums. We've got the strengthening forum, so strengthening existing systems, integration forum, integrating managed care, mental health, and substance use disorders. And then we had the data forum, and then we added or created a fiscal forum. And again, this is based off the business plan that was produced by CIMH, former CIMH and ADPI, using those recommendations. So we're just trying to keep rolling that out. We're looking forward to our October 2nd meeting. We've got a great lineup. We're going to be coming out with an agenda probably towards the end of the week or early next week. And just looking for a lot of stakeholder and partner input through that process. And also just feedback on how the process is going. So feel free to stop me. If you're seeing me in the conference, you have some thoughts, I'm happy to get that feedback. And with that, I'm done. Thank you.
Hopefully you can tell Brenda's got a passion for this performance outcome system, and thank goodness she does. Switching gears a little bit, I thought it'd be good for you to hear from Marlies regarding a pretty big major change in the counselor certification world that happened just recently.
Thank you, Karen. Before I get into that discussion, I just really want to take a moment also to thank Karen and acknowledge her for all of her work as she acknowledges our work. This last year has been just monumental. There's been so many transitions of organizations blending together. Talk about a year of change with ACA and things we faced in the field, and then these folks are merging in these and the acronyms and just so much going on. And there's been one real constant source in all that, and that's been Karen. And she just walked into this position, and she has the calmest demeanor, regardless of what's going on. And it's so funny because every once in a while, she's like, I'm stressed. It's like, you can't tell. You can't tell when she's stressed. It's like, well, I'm glad she said something because, just haven't even, it's true. But I want to, Karen took on a just tremendous job. And we looked that mental health had its own department. There was ADP, and it all came together under one person. And I remember talking to people like, well, whoever takes that job is going to be crazy. Not that you're crazy. Because she's not, and she's just learned so much about state government. I think that's been the most fun for us, because she's like, I don't understand. Why can't we just do this? And it's like, well, and then you have to explain the process. She's like, that's and then she takes it in grace and then just keeps moving forward. So I do just want to publicly thank her. It's been just a tremendous year, but we get so much support and guidance from her, and I'm not sure you all get to see, she's kind of behind the scenes a lot of the time and pushes us forward, but she's the one propelling us forward. So just really want to acknowledge. Now stop it. Yes. Yep. See, oh, look, here we go. And now I get to talk about counselor certification. So yeah, it's been, I get all the fun projects. It's awesome. But so counselor certification, so it's been about 2 weeks now that the Braeger Institute lost their accreditation with the NCCA. So Braeger Institute is no longer a certifying organization. And Braeger held about half of our registrants and counselors. So it's really been a huge impact to the field. The department did put out an information notice. Like Brenda said, we have our mental health SUD information notice. The notice just cites what the regulations are of when a CO is no longer accredited. The counselors that were in the CO that were no longer accredited, they have 6 months to move to another certifying organization. So now there are 4 remaining certified organizations. There's American Academy, there's CADAPT, and then, of course, most of you may know that CAR and CADAC recently merged, and that forms CCAP, and then we have CADI. So we have that information notice on our website. We're also going to be posting, getting the posting ADA accessible, but then it'll be on our website about the reciprocity. So if a counselor needs to find another CO, it gives them guidance as to what the 4 remaining COs, like, do they have to pay a fee? Do they have to retake the test? Just guidance like that. And so there's also information on our website if folks have questions to reach out to us. And I also just want to speak very briefly on the area of our workforce and counselors, and just let the you folks know that we have been in our spare time just really been continuing to look at our workforce and evaluate the current system that we have. As with other systems, we need to continually improve that. And so really, we've been doing a lot of research as to, while I understand that California, it has a different makeup and we recognize that, it's also a good thing to look at what other states are doing and just see what their systems are. So we've been really reaching out to other states, looking and seeing what they're doing with this system, because ultimately we can have great providers, but we also need to have great staff that are in the system. And in order to have that, make sure that they're properly trained and certified or whatever training that they need. And not saying that we don't have that, but really looking to make sure that we shore up any gaps and evaluate our system. The system was put into place in 2005, prior to ACA, prior to this integration with primary care. And so the department is taking a really hard look to see what sort of improvements we may be making. So once we have something more for you folks to give us feedback on, we'll be putting together some groups and bringing those ideas forward and sharing them with you. But I do just want to let you know that that is something that we're working on as well.
All right, so we have about, I don't know, 10, 15 more updates. Are we good? 5 minutes. I do get questions a lot. Yeah, so the KDA one's going to be really short. I do get questions a lot about the converting to DSM-5, and I just wanted to let you know we have said all along, you're still billing under ICD-9, or is it? Yeah, ICD-9. 10 doesn't start till next year. And so the conversion to DSM really wasn't the biggest priority with the ACA implementation this year. And we wanted to see what would happen with the ABA benefits and getting that rolled out as well. They also call that behavioral health treatment, which I know is very confusing, and I've raised that a number of times, but that's what the feds are calling it, so that's what we have to call it. So we want to get that all kind of settled. We had said we would start having some stakeholder conversations regarding DSM-5 conversion sometime in the fall. We're probably going to push that back a little bit, but it's still on our to-do list. So I just wanted to let people know that we haven't forgotten it, but you can still bill under ICD, so it doesn't really have a major impact. I do want to talk a little bit about KDA. And we did want to talk a little bit about the cultural competence plans. So I'll try and do this as quickly as possible. Regarding KDA, we have 52 counties that are providing and processing claims for ICC and IHBS, which is fabulous. We're very excited about that. 4 counties have the ability to process claims, but are not yet providing these services. And a couple of these counties, it's because they don't have foster kids. 2 counties don't have the ability to process claims, and they are not providing services, but we're expecting that that will change very soon. As you know, the court jurisdiction ends December 1st of this year. And so we've been working on the KDA legacy, which I may let Brenda talk a little bit about. But I also want to make sure that you know that there is the Joint Management Task Force. They have made some recommendations to administration with DHCS and CDSS, and that includes developing a shared vision, mission, and value statement, and then making sure that there's shared governance, policies and procedures, accountability, communication and oversight, and fiscal strategies, and how we will continue to have a point person, whether that'll be somebody that we have within CDSS or at DHCS. We're still trying to figure that out, but we're very committed to, even though jurisdiction will end, transformation takes time. In the first 3 years of this, we have been ramping up and trying to provide the services. But just because jurisdiction ends doesn't mean that we forget KDA and go away. That's not at all our intent. And so we want to continue these efforts. We think that it's going to have a tremendous impact on the foster kids that we serve, and want to continue working with CDSS on this. Therapeutic foster care, we did submit a placeholder state plan amendment for that. CMS has requested some additional information that is due back to them in September. The next court hearing, from what I understand, is the beginning part of October. And then the legacy system, I don't know, Brenda, do you want to jump in on?
I mean, essentially, we're just looking to continue working with counties, and so thank you to all of the counties who have worked so hard to really get KDA launched and get these services. Seeing the claims come in has been great. We kind of all look at the reports as they roll out and get really excited that we've seen such a great ramp up in these services. And, you know, we're kind of looking to work with the counties to kind of debrand KDA and just have the core practice model, ICC and IHBS and therapeutic foster care, have it go statewide and just become a standard practice and part of our system, and not a KDA thing, but it's just how we do business. And from DHCS's perspective, we're just going to continue working with counties, providing guidance, being there for you guys if you need anything. We're continuing to work through, you know, even beyond the end of jurisdiction, and working with our social services partners as well. I think we've built a really great relationship with social services.
Yeah, and in that effort too, just to say that, you know, we've been working with DSSS on their continuum of care reform. And I'm sure some of Rusty's providers can provide you a lot more information on that initiative than I can. But we do see that there is some overlap between those efforts and the efforts we have with KDA and foster care. And so we'll continue to work closely with DSS, as Brenda's been saying, to get those initiatives all rolled out. I do want to spend a couple minutes on cultural competency plans, because I know that that's always a big topic here, especially at the policy forum. Brenda, you want to do this? You want me to do this?
I'm happy to do it, yeah. So,
Cool.
Okay, relax, rest. Essentially, you know, the cultural competence requirements are in Title IX, and so MHPs are required to submit annual updated plans. The last one occurred in 10/11, which was prior to the transfer of former DMH into the Department of Healthcare Services. So coming into healthcare services, and you know, we have a new team and trying to figure out what to do with the reports that had been submitted, and you know, just after talking to our partners and stakeholders, decided to launch an effort to come up with a CCPR interim advisory task force, which we kicked off in April 2014. And this task force consists of 8 members representing various culturally and ethnically diverse groups and mental health consumers. They've been meeting on a bi-weekly basis to discuss possible revisions of the previous CCPRs, really with the idea of looking at this point at just the new class standards. So I think at this point for the next round, we don't want to make drastic changes to the requirements. We just are trying to take a look and see, you know, is there anything that we absolutely need to make changes to right now? I think at this point the group is saying there's not a lot of changes, there's some minimal changes. In July, we had Jeffrey Jacobs, who's the program manager of Think Cultural Health, in the Health and Human Services Office of Minority Health, and a colleague of his present on the class standards. Essentially, like I said, there's just minimal changes that we're seeking to make. And then we're drafting an information notice, or our team will be drafting an information notice. The idea is to put out guidance on the new requirements later this year or early next year. And Right now, for stakeholder involvement, the members of the current interim task force are going to update the stakeholder groups that they represent. And we're also looking to have stakeholder reach outs as at important junctions in the development so we can get some additional review and feedback before we take this out countywide or statewide. And we also are planning at the Behavioral Health Forum on October 2nd to have the cultural competence plans, I think, as an update on the agenda. So we want to just make sure we're keeping people apprised of the process and a little bit of work done, and then take it out to folks, get some feedback, incorporate that feedback, and just kind of have a close working relationship. So.
Oh, they're gone.
Here comes the hook.
Just quick, I know I'm being cut off here. The cane's coming. Couple things. The drug Medi-Cal emergency regs, I just want everybody to know that they were developed on 6/25. The F8, how we're responding to everyone from the feedback we've received on the program integrity drug Medi-Cal regulations is through FAQs, and we should be finished with those in the next 2 weeks. So we've incorporated all of the responses. I know there was a big concern with face-to-face. I just want to kind of point that out, that was removed from the regs, and we're not sure if everybody was referring back to the March 28th previous reg version, which had it in there, but the current version does not have that in there, and that's the majority of comments we got. So the current version is really what we're working off of FAQs. And then the two state plan amendments, 09022 and 13038 that Karen talked about earlier, we're currently drafting the IN information notices, and those should be out in the next week.
So just in the spirit of partnership, we want to thank you all for being our partners. We can't do any of this work without you, and I think together we have a stronger voice. And so thank you again for inviting us. We'll be here tomorrow and I think it's Friday. And so thank you again, and have a great policy forum.